What if timing and not just treatment was the key to successful cancer treatment? I'm Dr. Nathan Goodyear, and welcome back to the podcast. We're going to be taking a deep dive here into a concept that's really, I think, reshaping how we're going to approach cancer care in the future, but actually today, which is what we do at the Williams Cancer Institute. We bring the future of medical care in cancer to today, but it's approaching it through an immune-based strategy. It's called the circadian rhythm of the immune system. We often think of the circadian rhythm as the sleep wake cycles of cortisol and melatonin. And people even say, biological clock, these rhythms that are there and they're reproducible. But what if I told you that the immune system operates underneath the same 24-hour circadian rhythm? So what if we used this knowledge to align treatment with this fluctuation to optimize immunotherapy and treatment outcome in cancer? Could the secret be, again, not just lying in the treatment chosen, the approach chosen, but the timing of treatment? Dr. Jason Williams is joining me as we dive deep into this concept, the clinical application, and how this applies to you in the future of precision cancer care. Jason, as always, welcome back.
Thank you, Nathan. Good to talk to you.
Yeah, go ahead.
Interesting topic, and and how do we work around and deal with it, and what should we be doing in these type of things? Seeing more and more studies of what time of day the patient got their immunotherapy being an important factor. So it's one thing to look at, and then there's some other aspects of it. I mean, I had heard before previously, there were some groups that were doing like chemotherapies in that situation where there's the idea that cancer would start growing at certain times, and so if you gave chemotherapy at those times, then you matched it, you would get better responses. And I think there was definitely some data to back that. But on the immunology side of things, where it really kind of hit me was, about 6-7 years ago, we had presented a poster at the Society of Immunotherapy meeting, and a graduate student from Australia looked at our poster, sent it back to his professor, who was a guy named Martin Ashdown, who's in Melbourne, Australia, and he saw it and made a connection of our work with some work that he was doing with, the immune cycle. And he's saying that he had been studying this. Well, so when he saw it, he reached out, he contacted me. We ended up speaking. We talked several times. We exchanged many emails, and very, very helpful. As a matter of fact, the one of the studies that we were discussing at that radiation timing was, he was involved in that. I mean, I don't know if his name's on the paper, but he was involved, and he sent it to me. Just one thing of, I don't know Dr. Ashdown except for talking to him. He's a genuine guy who just, like all of us, wants to advance cancer therapy. And so it was really nice that he reached out to me and said, "Hey, I think I can give you some insight. I want you to know a few things." And so one of the things that he started telling me is that, he said, we were doing all these studies and we were looking at interleukin-2. Now, interleukin-2 has been FDA approved since 1992 for, originally for renal cell. May have some crossover melanoma later. I think in the late 90s got approval for some melanoma. But the problem is they're given it intravenous. It's super, super toxic, right? I mean, it's like, you generate a heavy immune response everywhere, but, put the patients in the ICU. I mean, it's just really problematic. And what were they seeing? They were seeing some patients were getting amazing response, and some people were getting terrible responses. So some people were really responding, and some people were made worse from the therapies. And that's where he started investigating the timing. So he started realizing that the immune system has a cycle where there's a part that wants to attack cancer. The effector part is active. And then there's the regulatory side, the part that protects cancer. It's active, and they bounce back and forth in this cycle. And when you give interleukin 2, you're stimulating the cells, but it depends on which ones are active at the moment. If you give it during the time when the anti-cancer cells are active, you get a good response. If you give them at the time that the regulatory cells are active, you made the patient worse. and that was really, it was, well, very interesting. And then he has, numerous studies with IL-2 to prove, basically what he's saying, and showing that you could time it and make the responses better. And that's obviously for like a, IL-2 being kind of more broad spectrum immune stimulant. I mean, again, that's the same. This is the analogy that I use, because I always use like the military analogy with the immune system. But this, like, you got a war, and you got your weapons, and there's two sides, and you just throw them out there, and you hope that your side gets them. But I mean, maybe they don't. Maybe the other team gets it, right. And so then that's the situation that we're seeing. Yeah, it was really interesting. So then, I had discussions with him, and looking like, so if there's this immune cycle, how can you determine it? And they had found a way of measuring the C-reactive protein, and they would do like high sensitivity CRP, and they would measure the patients for daily. And we ended up doing this type of thing as well. We've got some workarounds on it, so that we don't. It's not something we commonly have to do anymore. But there would be certain situations that you might want to do this, and but you measure high C-reactive protein, and you'll see it like come up and down and in phases, and it's roughly 8 days. So the immune cycle is roughly 8 days. Ashton says, he says, like a menstrual cycle, but the immune cycle, and it's 8 days, not like 28 or 30 or whatever it is for women menstrual cycle, right? 28, I believe.
Yep.
Uh, yeah. So it's interesting. I mean, but it's variable. And so then the question, cause like, so we started measuring it in patients, and we started trying to like change timing of certain things, change timing of treatment, um, and use it. But the problem was trying to figure out, because sometimes, like, by the time like the CRP was giving you an idea that maybe the effector side was changing, you're too late. And so you had to figure out like where is the exact spot. I mean, like, it's not so easy to say, okay, well, now the CRP went up, that's all like effector, and now it's down, it's all regulatory. It was a little more challenging. And the other thing is that, like, where do you start your therapy? Like, so for example, Ashdown was saying that sometimes in like radiation timing, what they would do is, like, as the effector stuff was starting to stop down, then starting like the radiation, where then you're hitting the base of the regulatory. I don't know. It's like, that's what we were discussing, that there's a lot to be figured out into like appropriate timing on these things. But yeah, more and more that comes up, I think, to optimize some therapies. I mean, we, our approach is kind of found that, like, when we hit a lot in the tumor, that we sort of disrupt the whole immune cycle, and we sort of make it, we change it and make it do what we want. And that's kind of, I think, been our method overall. But yeah, obviously for patients that aren't getting the type of therapy that we do, we're doing obviously advanced immunotherapies, hitting on all angles, hitting, from a T cell, B cell, myeloid, the whole gamut, right? We're hitting all over, and we're shaping that environment. But people that don't have that advantage, let's say they're getting like Keytruda, Opdivo, other standard immunotherapies, could there be ways to enhance that with timing? I think that's certainly the case.
That's an interesting point, because I was talking to a patient just yesterday, Jason, and I do believe he's going to be coming down to see us, and he is scheduled for radiation. And I said, "Oh, just curious." I said, "How is that being scheduled?" And he said, "Well, it's going to be scheduled in the morning and then in the afternoon, and we're going to do that day after day for several days in a row. And I said, well, why don't you ask your radiologist oncologist to elongate it and just do it in the morning, where the radiation is being applied into the morning? Because the article that you referenced related to Martin Ashton is a 2019 article that was published in Radiation Oncology. And it was looking at the time synchronized immune guided radiation of partially bulky tumor radiated tumors, targeting particularly the hypoxic area.
Regions, yeah.
And so I told the patient, I said, well, ask your doc at Sloan Kettering, ask him to do these in the morning. And I said, don't be confrontational. Just say, hey, I want to optimize it according to my immune cycle rhythm. And so I explained this article to the patient. Actually, I pulled up my notes for this podcast, and his wife was there and he was there, and we walked through it together. And he was like, this is awesome. Can you print it out for me so I can take it to my oncologist? I said, no. I said, just go to him. But, this is from 2019.
Yeah.
And I imagine, because he said, I don't think my oncologist is going to know about this.
Yeah. I know we were working, when we were doing a lot of combination with not a lot of combination, we were doing some cases combination radiation with our doctors in Mexico City. The doctors there were very receptive. It was so funny because we actually went to the radiation oncologist there who said, hey, look at this paper. We really want to do that. And she's like, oh, yeah, well, we can get this FMISO PET CT and determine the hypoxic regions. And they were able to get that for a while. It was funny because they had to do it through university, and it was through a grant that we couldn't pay them. Nobody would pay them, and they just did it, and they ran out of money, and they're like, okay, now we won't do it anymore. But we're like, well, we'll pay you, but they're like, no, we have no way to accept money. I don't know. So we've found it difficult to get more of those. We've since tried to determine these hypoxic areas because that's your areas you really want to target.
Why? That's a great point, Jason. Great intro, because that's a question that was going through my mind as you were talking there. Why is the targeting of the hypoxic areas of the tumor so important?
Yeah, those areas really are suppressing the whole immune system. It's like they're the nidus of everything. If you knock those out, I mean, it's like it would be like military wise, if those were your main military bases of your enemy, and you're blowing them up, right? I mean, that's what you're doing. I mean, those hypoxic areas are controlling it all. And when you do that, it makes it much easier to take down the tumor. So we use a little bit of our eyes on this on imaging, where you look and you try to see, regular radiologists don't do this. They look, they say, oh, there's a tumor there, it's 4 centimeters, 5 centimeters, got bigger, got smaller. But no, what's going on internally in the tumor? And sometimes it surprises me because you'll see a tumor where you're seeing an immune response and it's all changing. You can see it's improving. It might get a little bit bigger, right? That's the pseudo progression. And then, of course, the radiologist just reads it as well, the tumor there was 4 centimeters. Now it's 4.7 centimeters. It grew. That's it. And then, of course, everybody gets upset. And they're like, but no, but you're not looking at the tumors different. Look what the tumor looked like here and look what it looked like there. Look at them now. They're different. They're enhancing different. That is giving you an indication the immune system is attacking it. And so there are ways that you can do this on imaging in combination between looking at the CT, looking at ultrasound. You could involve MRI if you needed to. There's all sorts of options on that, but we can kind of try to identify these areas. And this part of what we're trying to develop for the future, is this radiomics type program where basically, we'd use the imaging and computer analysis, AI type of thing that would then identify the areas in the tumor and say, these are the spots. And I mean, you can get this detailed. I mean, on imaging, when you see, because it's interesting, there's a lot of data there.
Yeah.
I mean, you see a tumor and you see then you got the pixels, but in those pixels, there's other data that you can gain, and then you can start understanding, is there presence of carbic anhydrase, is there presence of certain chemicals, and based on certain pixelation structure of that, and that's how you can identify these type of things. And so this has been working on this for years actually, and just trying to, at some point, it's just a matter of like getting funding behind this. If we get the funding, we'll be able to develop it more. But we have like the base type of thing set. That's actually our company called Cancer Care AI. It has a radiomics idea built into that.
And radiomics would be just the study of what radiology.
Yeah, so analyzing the images, but like not just saying, well, that's a CT scan, but actually taking the pixel data and determining other factors where you could determine T cell infiltration, you could determine all sorts of stuff based on regular scans. I mean, human eyes don't really see it very well, but the computers, as you get it and analyzing, start picking up more, and also you get kind of cross data. Um, for me, what helped me out a lot was that I got a decent run of getting these special hypoxic PET CT scans that are called FMISO in Mexico City. And they did those for me. And then also the patients, I was getting FDG PETs, I was getting other scans. And so what allowed me to do was to look and see, oh, I see what the hypoxic areas are looking like on these other scans. I didn't know it, but now I know, and so now I can identify them. And so now I don't have to have that scan. I mean, again, it'd be nice to train computers and or have other people doing this, but I'm doing it with my own eyes because I just have learned and see it. But I can take and see the other scans that this is probably the hypoxic area, and so you can target. I mean, sometimes it's hypoxic area is big. I mean, sometimes they're small. Um, when you can involve ultrasound in this, I think sometimes we're identifying even another dynamic to it. I think that we're able to see some of these things. I mean, so like when I see a tumor on an ultrasound, if you see it dull, dark, well, that's probably all your hypoxic areas. And then you start treating it, you'll start seeing areas that start getting more echogenic, and the areas to target. That's so
Yeah, a couple things I wanted to touch on there because I've noticed that when the team gets together and we discuss the different cases, is there's a difference between a radiologist, right, just reading an image, and an interventional radiologist that's actively involved in clinical care, reading an image. There's very much a clinical application to the image reading, which provides depth. And that's something that I've been amazed about because you were kind of describing that where the radiologist may say, well, it was 4 centimeters, now it's 4.7 centimeters. And it's like, well, but what just happened? Because when I talk to patients, it's always interesting. And when I talk to them, I said, this is in the range of pseudo progression. They go, well, what's that? And I said, well, what did we just do 10 days ago? They said, well, you activated my immune system. I said, exactly. What would we expect? They go, I don't know. I said, well, what if you walked outside and sprained your ankle? What happens there? The immune system is activated to repair that injury. What are you going to see? They go, well, it's going to swell. Right, exactly. It's going to swell. Now, what is that? That's the immune system being activated to that area. What's different here is that's an injury. Here, it's intentional. It's to target and activate, the immune system. But you also touched on hypoxia. And another question I get a lot, Jason, I'd love to hear you explain this to the audience. People go, you mean the whole tumors, not hypoxia? You don't just blindly stick a needle anywhere in the tumor?
yeah, yeah. Surprisingly, it could be all hypoxic, but there's also will be different degrees of hypoxia as well. And so that's the other thing that you kind of see with it, and yeah, you can kind of identify those areas. And yeah, that was interesting stuff. That once I got access to those FMISO pets, that then educated my eyes to then know, oh yeah, now that this was it actually, well, it surprised me because I remember when I first started having the patients and they were getting these FMISO, hypoxic targeting PET CT scans. I was thinking, I was like, before I saw the scan, where's going to be the hypoxia? I'm going to guess. I'm going to make the guess, and then let me see the scan. Like I'm looking at other imaging, and I'm going to make the guess. Was wrong, like every time at first. You would think what you should think the center of the tumor. Turns out the hypoxic areas tend to be much more on the periphery.
Mm.
of tumors. Much more often on the periphery of the tumor than the center of the tumor.
Isn't that where you tend to see most of the hypermetabolic activity as well? So does that connect those two together in terms
Yeah,
of driving the other?
I mean, it does. It a lot of times it is, I think, true to me. Like if I'm seeing like an FDG PET, so looking at glucose uptake, and I see an area that's like super hot. I mean, and you can have tumors hot, but then you have areas that's like hotter. And I'd say, well, that is probably problematic. It's probably hypoxic as well, even though it's super metabolically active. But that's what we were kind of identifying on the scans. Originally, you would just think it would be the areas that didn't have the vascularity, I mean, because the outer part would be closer to vascularity. Center part should technically have the least amount of oxygen, you would think. So, but turns out to not be that way. Uh,
It's kind of that
and
clash zone. It's kind of that clash zone, though.
yeah,
It's kind of like the front line, if you will, so to speak.
yeah, it's so obviously like having all these different things put together and seeing and then learning, and it was hugely helpful for us, and that's helped us evolve, our therapy to just get better and better, and we're always, I mean, look, every day I'm always looking what are the other things that we can do to make this better. It's not it's not. I mean, I'm always thinking on this, but yeah.
What was
So
great on this study was they looked at 8 patients. So it was actually humans. So it's not like it was mice, though. I mean, you have a lot of experience working with mice, but when we actually translate that to humans and human studies, it really gives us great confidence. But they divided into 2 groups. They divided into the most favorable, which was pre-trough, so pre-low point of, and they used high sensitivity C-reactive protein, lactate dehydrogenase, and lymphocyte monocyte ratio. And then there was a least favorable, which was pre-peak, which was the highest point. And what was amazing between these 4 different patients, 4 in the pre and pre-trough and pre-peak, which is the most favorable and least favorable, was the actual response rate was remarkable. And so I want to just repeat what was said here in the study and then get your take on it. Um, they found that there was significant more bystander effect in the highly favorable, which was pre-trough. And this led to, of the 4 patients, 3 having complete responses and 1 having 80% response. So translated across all 4, that was 95% response rate, if you look at it that way. And of the 4 patients that was at the highest levels, the pre-peak, which is the least favorable, they actually found overall a 35% response rate. They had 1 patient with complete response, but overall 35% response rate. So it shows there that not just the treatment, but the timing has a huge discrepancy
yeah,
in
yeah,
treatment out.
yeah, yeah. It's amazing. I mean, there's so much complexity and all this stuff, and then you know trying to get it all together. But yeah, it's interesting. But I think from our standpoint, we definitely learned that we want to target hypoxic areas. That's something that I don't think would be common. You know, other doctors that are doing ablation are not saying, "Oh, I'm going to ablate the hypoxic area," because they don't even know it. They're not even discussing hypoxic areas at all. And so that's different. And we try to be more precise on things. And this is stuff that we want to educate other doctors on, so that they can be helping other patients. So
You
hope
know,
maybe
I thought earlier when you were talking about interleukin 2 and we were talking about circadian rhythm, um, there's some research out there, not any updated recently, but, last 20 years, where they were doing, instead of the high dose interleukin 2, because of clearly all of the vascular issues and the edema and the leaking and just massive issues that it created, but they low dose interleukin 2. And then combining that with, interestingly enough, melatonin. And interestingly enough, melatonin, high dose melatonin here is one of those key regulating, circulating circadian rhythm signals. So I just find it interesting there that low dose interleukin 2 plus melatonin, high dose, there's actually research out of Europe showing, hey, this is impactful for immune activation.
yeah, yeah, interesting. Yeah, and I used IL-2 intratumoral previously. Gosh, I mean, 25 years ago at least, or so. I mean, a long time ago. And I thought I saw some responses. I mean, I thought it was like helpful. But we just kind of ended up going like in other directions, and then now obviously we deal a lot more with like very specific, like certain you know agents that are stimulate the innate immune response and get the immune infiltration going. We've got agents that stimulate the activated T cells, B cells, NK, and such. And then we've got the blockade of like the checkpoints and stuff that would shut it off, and that's sort of the thing about. And then you could add even a fourth aspect of also always pushing the myeloid cells, like the tumor associated macrophages, and trying to get them to either be anti-cancer. And that's like our approach to immunotherapy, and that's where we see our main success.
I want to bring in another article because it's going to tie into the immune checkpoints. Again, check out the show notes. All the articles will be listed there for you to dive deep into, and I encourage that. The title of this article was Circadian Control of Tumor Immunosuppression Impacts Efficacy of Immune Checkpoint Blockade. Was actually published in 2024. But I want to read you kind of a mic drop statement here. Administering anti-PD-L1 therapy at times when myeloid-derived suppressing cells are most abundant enhances treatment efficacy. They said, we leveraged these data to show that anti-PD-L1 administration was most effective in the early active phase of mice.